Hello everyone, my name is Jinyoung Park. I'm from the Department of Periodontology at Yonsei University, the College of Dentistry in South Korea, Seoul. So it's a great honor to be here today speaking at the Dentium Global Seminar. And so let me start my presentation. Okay, so the topic of my presentation today is less intervention, better biology. In particular, I will talk about unfixed guided bone regeneration technique and particularly how to achieve better outcome in the anterior aesthetic area, and also I will talk briefly about utilization of bright tissue level implants. So, when we are faced with a ridge defect in the aesthetic area, we need to have a very planned approach. In this particular case, we can see that there is a vertical component of the defect. And when you also see from this occlusal view, there is also a horizontal component of the defect. So, in this kind of a case, I will utilize a particulate xenograft material. And in this particular case, I used a 100% bone substitute without any autologous bone. And then it was covered by a non-resorbable PTFE membrane, which was fixated using multiple pins. And when you're using this kind of membrane, it is crucial that you achieve stability by using as many pins as possible so that there are no moving parts after the flap is closed. So this was the healing. And when we re-enter the site for implant placement, we can see a very well-healed ridge, despite only using 100% xenograft. And afterwards, to increase the volume, to achieve a more soft tissue in the papilla area, we perform soft tissue augmentation. In this case, I utilized the connective tissue graft. So this was the beginning. And then this is the healing, and you can see with the temporary provisional restorations, we can check the level of the soft tissues. And since we had some relapse of the vestibule, the mucosa, which was encroaching towards the coronal area, we decided to perform additional apically positioned flap at the second surgery. So here, the second surgery was performed and pinholes were made at the implant sites so that no flap was elevated. And then we can use a collagen matrix to cover the area of exposed periosteum when we perform the apically positioned flap. So, compared with the initial presentation, we have a vast improvement in harmony with a high smile line where there was a lot of exposed areas. So, when we are choosing the barrier membrane, there are several design criteria. So these are the 5 pillars, you could say, when we are selecting the membrane. These are the ideal characteristics that a membrane should have, and that includes tissue integration ability, also ability to occlude the soft tissue cells from invading into the defect space, and also the membrane has to be clinically manageable, and the membrane needs to maintain the space within the defect site, and finally it should be very biocompatible. And when we consider the PTFE membrane, it can be favorable in size which requires space maintenance, like the case that I just shared with you previously. Especially in vertical defects, this can be very useful. However, nowadays collagen membranes are much more favored by clinicians because it has easier maneuverability during surgery. And especially when the membrane can sometimes become exposed, collagen membrane has the ability to heal spontaneously, unlike the non-resorbable membranes. So this material is the most popular membrane nowadays used for guided bone regeneration. However, the collagen membrane, when it becomes soaked in saline and blood, it loses its structural stability. So many clinicians like to fixate the collagen membranes using devices such as membrane pins, bone tacks, or they can use membrane stabilizing sutures. However, this technique using the pins can be very technically tricky during the surgery. So we can prefer methods that can avoid using the pins if possible to obtain stability of the graft. So we developed this technique called retentive flap technique, and we produced many articles using this technique, and also comparing techniques that involve pin fixation opposed to no pin fixation. So we had 3 preclinical in vivo studies. We also published 2 retrospective clinical studies, and we also performed a randomized clinical trial showing that the 2 techniques of membrane fixation and unfixed techniques using the retentive flap technique has no differences in terms of the buccal bone thickness. However, this article is yet to be published. So when we are considering unfixed GBR techniques, we need to think about the bony envelope. So there are 2 types in general, where the teeth are retroclined, and this type where the teeth are within the bony envelope. And there are teeth that are very proclined, which are outside of the bony envelope. So when we consider this situation of a proclined tooth with a root that is outside of the bony envelope, and it has the labial component with the buccal wall that is outside of the bony envelope. So when we consider extracting this tooth and placing the implant, you can imagine that the labial bone will have disappeared and you will end up with a defect. It can either be a dehiscence defect if we have a lot of space within the gap, or we could end up with a perforation of the buccal wall at the apical portion, which can cause another type of problematic situation. So when we are performing GBR in this anterior area, we need to perform bone augmentation to this outer line, the yellow line, so that it covers the entire area of the implant. And by doing this, by over-augmenting this area, we are enhancing the bony envelope. So in these kind of scenarios, after we extract the tooth and perform GBR with simultaneous implant placement, we need to perform over-augmentation of the hard tissue. So this is after closure of the flap, after bone augmentation. This is 1 month after the surgery. And after 6 months, we can see that we have a very nice situation with increased buccal volume around the implant. And when we look at the serial CBCT images, we can see comparing the pre-op to post-op, we have a very augmented buccal bone of the implant. And after 6 months, this augmented volume is quite nicely maintained. And then when we look at the midterm results after 1 year and slightly longer term results after 3 years, we can still see that this augmented bone is very well maintained, and there is a corticalization of the buccal wall, which is very nice to see. So when we look at the clinical photos, we can see that we have a very nice outcome in terms of the pink aesthetics as well, not only the bone. So you can see that when we have a good augmentation of the bone, these kind of cases can be achieved without even performing any soft tissue augmentation. So now let's have a look at this case, which was an unsuccessful case in terms of GBR outcome. She had a missing right central incisor, and this is a CBCT taken before extraction to assess the availability of immediate implant. So this was clearly a case of a very prominent root position. We can anticipate that the implant will perforate the bone in the apical region and create a fenestration defect. So this is after flap elevation. We can appreciate the defect there. And in this case, we were not able to place an implant in a favorable position. So we decided only to perform a staged GBR. And I made a sausage technique using multiple pins. And let me give you one clinical tip. You can see here that I placed some pins in the apical region of the graft. But I would recommend never to place pins in this area, and I will explain further why. So after I closed the flap, I was quite pleased with the result, and here is the serial CBCT view after bone augmentation. We can see after 6 months we have some consolidation of the graft material. So we were able to place the implant within the bony envelope after when we re-entered the area for implant placement surgery. And this was the quite disappointing outcome when we looked at the CBCT after 1 year of placing the implant. We can see that most of the bone that was surrounding the crestal area of the implant had been resorbed. So we can see that this stability of the augmented bone was not so successful in this scenario. So how can we increase the longevity of the augmented tissue, and how can we avoid this problem of the loss of the grafted volume in the long term? And my answer to you would be to utilize the surrounding bone anatomy. So I love this analogy of building a sand castle when we're talking about bone augmentation. The sand is not a stable material, likewise the particular bone graft materials that we use. Therefore, it needs to be supported. If we can utilize the surrounding landscape like this, picture on the right, we can build a fortress because it is protected by the walls of the cliff. Now let's see. The situation on the right is much more stable compared to the situation on the left. Now can you see the difference? If you can see the difference, now your eyes have been opened, and all of you will be able to do a great GBR which doesn't require pin fixation if you understand this concept. This has many more advantages than just stability. Now you can utilize a greater area of the native bone for angiogenesis of your graft. So let me consider the unfixed GBR and how we can do them step by step. So here we have a horizontally resorbed ridge. When we elevate the flap, go more apical until you meet the anterior nasal spine. This is the base of your bone construction. So now you can also see that I have already made a periosteal releasing incision in this area. Right after flap elevation, this is more advantageous because then you can control the hemostasis during your bone grafting. Okay, and now the implant is placed, and we can still see that there is a buccal bone defect. Now we perform bone augmentation. You can see that the graft material is built up from the nasal concavity all the way up to the crestal area. No autogenous bone is used here, only xenogenic bone substitute with the collagen membrane. So the collagen membrane is used to cover the material. Since the membrane does not function to provide stability, all it does is containing the particular bone material from scattering. So I would say any type of collagen membrane will be suffice in these kind of cases because the stability comes from the bone substitute materials, not the membrane, since you're not going to fixate the membrane with any pins. So the sutures are now placed. And now, as you can see, we have very stable graft. No fixation pins, screws, or membrane stabilizing sutures, just utilizing the anatomy. So here is the pre-op up to the 4 months. Okay, so let me speak to you about the vertical ridge defect. So you could ask me, okay, the technique will work when you have a horizontal defect, but what about if you have a vertical defect? Will it still work? Well, I would say in a single tooth vertical defect like this, we can utilize the non-membrane fixation technique. So you can appreciate that this patient has some periodontal issues as well. And when we take a CBCT, there is clearly a vertical defect in the area of the lateral incisor. So when we elevate the flap, you can appreciate the severity of the problem in this area. We also have a denuded root surface on the distal of the central incisor as well. So we also need to perform guided tissue regeneration as well as guided bone regeneration. And for this purpose, I decided to combine autogenous bone scrapings with synthetic bone. Used in this case was Osteon 3. And then I combined it with a soft block. It's a collagenous bone substitute with a collagen membrane. So membrane was placed into the palatal flap like so. And then what I do was place a soft block base at the base of the anterior nasal spine. So we create a larger floor so we can really construct a stable base of our graft. And then I place the autogenous bone mixed with the bone substitute. And then cover it with the collagen membrane and close the flap. So compared to the pre-op, we have a very over-augmented area at the post-operative, and after 6 months, we have a stable bone which is consolidated. So this is the situation. You can also see in the other view of the occlusal view that we have reconstructed the bone, and you can see that the reconstruction only occurs up to the bony envelope. So any of the bone that is really over-augmented in this labial area becomes resorbed. So we re-enter the site for implant placement. We can still see that there is some particles of the synthetic bone graft left there, but it's nicely integrated with the surrounding native bone. So in this case, to increase the volume even further, I decided to perform connective tissue graft. And since there is no periosteum to fixate the connective tissue graft in this case, because the flaps were elevated in full thickness, so this technique I call suspended connective tissue graft. What I do is I use a mattress sutures to tie the connective tissue to the adjacent teeth on each side. And then I simply close the flap. So compared to the initial situation, we have a much better situation for making implant restoration. In order to take care of the mucosa and the mucogingival junction, we perform a strip-free gingival graft with apically positioned flap, and this was the final result. So, okay, so we can utilize the anterior nasal spine to perform simple GBR without any pin fixation in the anterior region. So you may also ask, how about in the posterior region? What technique do we need to use to avoid pin fixation? So here we have a very typical clinical scenario of a sloping defect wall in the lower left second molar area where I placed the implant. So to test this kind of model, we tested it in an in vivo canine model. So we placed 2 implants on each side of the jaw. And what we did was we performed GBR with deproteinized bovine bone mineral or Osteon Zeno, which is from Dentium. And then we covered this area with collagen membranes, 2 different types of collagen membranes, either BioGuide or collagen membrane 2. And we also compared fixation and non-fixation. As a result, we achieved good marginal bone levels irrespective of the graft material. In the 3D micro reconstructed images representatively revealed the level of augmentation, which was up to the crestal area, the platform of the implants. Interestingly, we found that for the combination using Osteon Zeno and collagen membrane 2, we were able to achieve good augmented tissue thickness at all levels of the implant, irrespective of membrane fixation. So we know that these materials have good biocompatibility, and they can work if you apply the right techniques without pin fixation. So here we utilize this combination of the materials, and we apply them quite frequently on clinic as well. So technically, the implant must be placed correctly, which means that it needs to be within the bony envelope and against the lingual bone. And then the materials are placed slightly over-augmented, and it was not fixated in this case. And here is the final outcome. And you can see the serial CBCTs of baseline, post-operative, 4 months, and after 1 year, you can see that the augmented tissue is very well preserved. So to be even more efficient and avoid grafting altogether, we can also consider the use of a narrow implant in these kind of narrow ridges. Okay, so a tissue level implant with an external type connection can certainly be a viable solution due to the stronger material strength in the connection area. The classification according to implant diameter is as so. So technically, the narrow implants are those that have diameters of 3.5 millimeters or less. Currently in the literature, a direct comparative data is lacking comparing narrow implants to standard or wide diameter implants. In this case, the bright tissue level implant can certainly provide a viable option. As you can see, the implant can be placed without having to perform any bone augmentation, because we utilize a 3.5 millimeter diameter implant here in the posterior ridge. And in fact, we placed 3 implants in adjacent teeth. And we can observe maintenance of the soft tissue and bone up to 1 year in this case without any complications. And we can see the marginal bone levels are very well maintained in the periapical x-rays. So this case that I showed you just now was part of a randomized clinical trial that was performed at Yonsei University that compared narrow diameter tissue level implants with wide diameter tissue level implants for molar replacement, and the result was followed up to 1 year. So the participants were randomized, and there were 12 that received wide implants, and the other 11 received narrow implants. And if needed, these patients also received bone augmentation procedures. So you can see here that typically when we place a wide diameter implant, we end up with some dehiscence of the implant on the buccal aspect and ending up having to perform a guided bone regeneration. However, in a thin ridge like this, if you place a 3.5 millimeter diameter of a tissue level implant, you can avoid having to perform a technique, very sensitive, technique-sensitive bone augmentation procedures. So we can see that there was no difference in the marginal bone levels between the two groups, and there were no complications in the narrow group. So a clear advantage in the narrow implant group was the operation time. It took much less time. About 10 minutes of surgery time was reduced when we performed the surgery using a narrow diameter implant. So both implants work well, but narrow diameter implants, you can simplify your surgery. So, in summary, I would say the graft stability can be achieved using anatomical structures. So, in the anterior region, you can utilize the anterior nasal spine. And secondly, successful bone augmentation can be performed without any membrane fixation if you understand the anatomy and healing. And thirdly, narrow diameter implants, bright tissue level implants, can be a viable solution in narrow ridges in the posterior region. Okay, so thank you very much for your attention, and goodbye. Okay, so when using the retentive flap technique, what are your key criteria for incision design, flap elevation, and achieving tension-free primary closure? Okay, so for incision design, I would utilize a crestal incision and sulcular incisions. So crestal incision in the edentulous area, and then sulcular incisions around the adjacent teeth. And you can make a vertical releasing incision in your adjacent teeth if needed. But in the anterior area, nowadays I like to just perform sulcular incisions on the adjacent teeth. And if you need greater flap mobility, then you simply extend the flap horizontally rather than placing vertical incisions, which can create scars in the long term. And then after elevating the flap up to the nasal spine, and then you perform the bone augmentation procedure. And to achieve the tension-free primary closure, you simply have to perform the periosteal releasing incisions. And if you understand, especially in the anterior region, where the muscles are situated, you can do these periosteal releasing incisions without creating too much trauma to the soft tissues for these patients. And typically a good way of doing that is to make the incision near the mucogingival junction, and then you extend superficially to the muscle tissues, extend apically. Okay, I hope that answered your question. So let's move on to the next question. Okay, so with bright tissue level implants, in which cases would you do you think you can reduce or avoid posterior GBR, and what are the main limitations? So I would say for the bright tissue level implants, the main advantage of this implant is the external hex design. So this means that you don't have to have a thick wall around the platform which doesn't break, okay, if you have an internal connection with a Morse taper. So you can have a stronger connection, but then this allows a narrower diameter of the platform as well. So if you look at the catalog of the bright tissue level implants, you will see all of them in all thicknesses of the implants, you will have the same size of the platform, which is 3.8 millimeters. This means that if you have a narrow platform, then you have more space for the tissues. So actually, I think the biggest advantage of using the bright tissue level implant is that you can have more space for the healing of the tissue, the soft tissue, which is very important for long-term stability of the marginal bone levels, as well as aesthetics of the implants, and having the papillas around the platform, the thickness of the tissue is critical. So in the posterior region, even if you place a standard diameter implant, you can still have a slightly narrower and concave emergence profile of your abutments. And you can really have a very favorable outcome for the tissues. And I showed the randomized clinical trial that we performed at Yonsei, and all of the cases, even in the posterior ridges, a very wide ridge, when a narrow diameter implant was placed, the reaction of the tissues around the implant was excellent, and we had no complications regarding clinical outcomes and radiographical outcomes. So I think I was at first very skeptical of using narrow diameter implants in the posterior ridges before. And even nowadays, if I am placing implants in the posterior region, I would opt to go for the standard diameter or the wide implants. But there are some cases like medically compromised cases, or very old patients who may not, tolerate very technique-sensitive GBR procedures. Then these tissue-level implants can certainly be a viable option. Okay, so I think that brings us to the end of this lecture. So thank you very much, everyone, for joining me. I hope we shared some valuable knowledge that's going to be useful for your practice from tomorrow. So thank you very much for joining me, See you again. Actually, the next the global seminar will be held on the 4th of September, so please join us again for that as well.